Hi everyone. All right, so today I am very delighted to introduce our joint seminar speaker, Professor Cohn, who is an Alfred Turnow Professor of Industrial and Operations Engineering at the University of Michigan, where she also holds an appointment in the Department of Health Management and Policy in the School of Public Health. She is the faculty director of the Center for Healthcare Engineering and Patient Safety, as well as the Chief Transformation Officer for Michigan Medicine. She has an AD from Harvard in Math, a PhD in Operations Research from MIT, and her research interests are in combinatorial optimization, particularly focused on healthcare and aviation, and the challenges of optimization problems with multiple objective criteria. Now, Amy has won a number of major awards, and I will not enumerate them, but I have tried to keep track of what she has done since we received this introduction. So as of last week...
So here you go. He's just going to keep going and going.
Dollars? I mean, what are you talking about? So as of last week, she was the recipient of one of the highest accomplishments, one of the highest awards in our field. She was named one of the Cohn Fellows. For her contributions to improving healthcare delivery, providing experiential learning opportunities in healthcare to operations research students, and for her leadership and service to informs and the profession. So with that, I'm honored to introduce and get started.
Thank you, Vikant. Thank you very much. Thank you, everybody. I don't know if I'll need these or not. So it's great to be here. I've been to Dartmouth a couple of times, and it gets better every single time, so I hope to be here again. I want to give a little bit of a warning that I'm going to give a slightly different talk, perhaps, than a more traditional research talk or the talks that I gave earlier in my career. But I want to really build on some of the conversations we've been having throughout this visit about how we think about whether you call yourself an operations researcher, an industrial engineer, a systems engineer, biomedical engineer, convert, how we think about working in healthcare and the impact that we can make. So I'm going to talk about some stuff that's unfortunately kind of not very cheerful. So let's talk about some good stuff first. There is amazing work being done in medicine. So this idea of like 3D printing for artificial blood vessels and, gene therapy to restore hearing and a cure for sickle cell anemia. There is stuff happening in our research communities every single day. Every day that you open the news, you can see some breakthrough that is absolutely miraculous. That's the good news. The bad news is that's not necessarily getting to patients. And not only are these new miraculous treatments not getting to patients, patients aren't getting the things that we already know about. So I have a colleague with cystic fibrosis. She is alive because of the new medications that they've recently developed. Colorado's not getting those medications. TB, we can deal with TB, well, we're not. Opioid issues that we can deal with, but we're not. And it's not, okay, not everybody can get the rare gene therapy to cure a rare, it's normal stuff. So sickle cell disease affects, if you don't know about sickle cell disease, that's actually probably a good thing. It's a bad disease. It affects a large number of children, predominantly children of color in this country. It is painful. It keeps them out of school. They have strokes. They ultimately, many times die from this. So how exciting that we have this new gene therapy, this new therapeutic that could cure sickle cell. But 80% of children in the United States who have sickle cell disease do not get the standard medications that have been the standard of care for decades. These are medications that keep them in school, keep them out of pain, keep them from having strokes. They're not getting that. Okay, maybe that's still too remote for you. 25% of women during pregnancy in this country get no prenatal care in their first trimester. 2% get no prenatal care, period. New appointment in neurology. You may have heard this term, the silver tide, silver wave, silver tsunami. That means that many of you are going to be stuck worrying about caring for me in the very near future, and a whole lot of others who are going to be of an age. We are having more and more top-heavy. If you've heard of Alzheimer's, Alzheimer's is affecting an enormous number of people. One of the challenges in in healthcare is we are living longer, which means we can then get sick with other things. This is personal. I've said to many of you before throughout today, my dad is in the early stages of Alzheimer's, and he is here today. Actually, he's an old New Englander, and he drove up with me so that he and my mom could see the leaves. And, we've been talking about his days at Holy Cross playing Dartmouth football and whatnot. Alzheimer's moves fast. His neurology appointment's in January. We scheduled it this summer. A third of us don't have a primary care doctor. Primary care doctors identify and then treat our diabetes, our heart disease, our cholesterol, our blood pressure. Okay, so this is kind of concerning, right? We're doing all of this incredible stuff to figure out ways to treat diseases. And it's the healthcare system that's killing us. We're not getting it, okay? This is everybody's problem. No matter how wealthy you are, you may still spend days, weeks in an emergency department in psychiatric crisis waiting to get an inpatient bed. It doesn't matter how important you are or who you know. Every one of us is at risk. God, do I sound like a downer on a Friday afternoon? At the end, we're going to be hopeful and you're all going to go out and save the world. But this is serious stuff, right? So anybody in this country, leading cause of personal bankruptcy in this country is health debt, right? Any one of us can get hit with something unplanned, unexpected that we did not cause. Nobody gets ovarian cancer because they made bad choices. But if you are poor, if you are a minority, if you have a substance abuse issue, if you are mentally ill, it is so much worse. And it is not just about individuals, it's about our society. What are we up to, Jeff? 19% of GDP, 21% of GDP? 21% of GDP. I mentioned the bankruptcy rates, biggest jump in healthcare costs to employers. And guess what the employers do with those increases in healthcare costs? They pass some of it along to their employees. So you're taking home less money because more is going to your healthcare, and you're paying more for goods because the companies have to ratchet up prices to manage the healthcare. Diabetes, we've heard a lot lately about capping of insulin. If you're not following that and don't understand the implications of that, diabetes means you lose a foot, you lose a leg, you die. You can manage it with medication. That medication can be expensive enough that you don't take it. Alzheimer's drugs, it's fabulous that they're coming out with these new Alzheimer's drugs, and there is no way that this aging population is going to be able to afford those drugs. So, why am I telling you all of this in an engineering seminar on a beautiful Friday afternoon? Because there are a lot of things that I can't fix, that I don't know if any of you can fix these, fabulous, but our payment system in the US is a cause for our challenges, right? You cannot talk about what's going on in healthcare operations without understanding the economics, the alignment of incentives. There are inequities and biases in society that affect healthcare in a dramatic way. We have capacity limitations, and those capacity limitations, there are something like 300,000 cardiologists in the country and 7,000 geriatricians. Do you know what a geriatrician is? Anybody know what a geriatrician is? One, thank you. A doctor for, we'll say older people, because I discovered in a seminar where we brought in a geriatrician last week, and I have a sense of what it means to be old, and evidently it's not that far away for some of us. So geriatricians care for people old enough to be on Medicare. Let's just leave it at that. Geography, specialty, right? Certain diseases, certain conditions do not attract people into those fields. These are not easy problems to solve. But a lot of the problem is because it's just really complicated. It is a complex system. And for many of you, hopefully, when you hear complex system, like your heart rate goes up a little bit, and those in the back sleeping start thinking a little bit more like complex systems are something that we can start to sink our teeth into a little bit, okay? So I can't solve racism. I cannot solve the aging population. I cannot solve the opioid pandemic. But I'm not so bad, actually, with complex systems. So let's see what we can do. But first, I want to very quickly, and I can barely see the clock over there, so I'm asking you all to just periodically yawn, which will trigger me to go, oh my gosh, I need to talk faster. Nicely done. Nicely done. See, folks, that's what you do to be nice to a guest. When they ask you to yawn, yawn. So let's talk. For those of you who hopefully, my hope is that many of you, especially our younger graduate students, have not had a lot of experience with the healthcare system and therefore may not realize how complicated it is. So when I think about TV shows about, has anybody, okay, let's see how old you are. Have you watched House? Have you watched Grey's Anatomy? Have you watched ER? Okay, we got a couple of Price and George Clooney fans, right? How many TV shows do you see about primary care clinics in Midwestern towns that are fairly middle, right? It's emergency departments, it's operating rooms, it's in the hospital. Those are not three different things. Those are one thing. Because when you're in the emergency department, sometimes we have to admit you to the inpatient hospital. And when you have surgery and you're done, sometimes you have to go to the hospital, right? So if I'm going to try and fix things in the hospital, I've got to be aware that I'm going to be impacted by and have impact on the ED and the surgical centers. Also, when you're in the ED, you could get sent to surgery, which means, among other things, that when one person comes into the ED and needs surgery that was not intended, we are now disrupting the person who planned, because of capacity, possibly months ago, their entire life around having surgery. Oh, by the way, you can be inpatient and deteriorate and need to go urgently to surgery. Also, at some point, you need to leave these places. So as a systems person, I tend to think about input, throughput, and output, right? What is the output from the emergency department or the inpatient beds? Well, in a lot of cases, you need to go to a skilled nursing facility. And the reason to go to a skilled nursing facility is you're not healthy enough to be at home, but we need your bed, right? It is too expensive. You don't need the resources of being in a hospital. We need you to go someplace else. But if there is no skilled nursing facility bed available, then you stay in the hospital. You don't need to be in the hospital, and I need to be in the hospital, but I can't be in the hospital because you're in the hospital, because you're in a skilled nursing facility, or we maybe don't pay the people who work in skilled nursing facilities enough, or maybe we have, et cetera, et cetera. Oh, by the way, a lot of these people need testing. MRIs, ultrasounds, we're going to talk a little bit about stress testing. And I might go from the ED to get an MRI. And based on the MRI, I might then be sent to the operating room. I might be an inpatient who gets sent to get an MRI. And maybe we're not discharging you from the inpatient space until we have an MRI to make sure that you don't have X, Y, and Z. So you're going to keep taking up space in that inpatient bed until we get you with the MRI. But the MRI is being used for the emergency department patient to decide if they need surgery, and therefore another emergency department patient can't get admitted. And even though they don't show it on TV, there's a whole lot of care going on in outpatient clinics. And in fact, if we had more care going on in outpatient clinics, do you know where we would need less care? Come on. If you answer it, then you're done for the whole talk. So if we had fewer, because guys in the back, I see you. I want you to be seen. So If we had more people getting outpatient care, where do you think we might need less care? Yes. In the ED? Yes, absolutely. People go to the emergency department because the little thing that was wrong that I would have gone to my primary care doc and gotten taken care of turns into a big thing that's wrong because they don't have a primary care doc. They don't go to the outpatient clinic. And oh yeah, patients sometimes go to the emergency department and get told, you're really sick. You need to go, they go to their clinic and the clinic says, you're really sick. You need to go to the ED. Or I call and my primary care doc says, we're closing in 10 minutes and we don't have any appointments tomorrow, so go to the ED. And when you get discharged from the ED, what do they usually tell you to do in follow-up? Somebody? What do they tell you after the follow-up? Who should you see next? Your primary care doc. And by the way, when you go to your primary care doc or your orthopedist or your rheumatologist, they may send you in for surgery. All of these people get testing. So some of you should be excited now, right? Like, this is a complicated system. And by the way, the people who work in emergency departments don't have tremendous visibility into what's happening in a primary care clinic. And the people who work in operating rooms don't necessarily understand the nuances of how the MRI clinics are run, right? Understanding all of the connections is an awful lot to ask of people. But that's where we come in. This is where I was part of our COVID response team, and we got, like mugs and T-shirts and stuff that talk about, frontline heroes and, people who wear capes. So I'm putting my cape on now, and I'm like, as someone who did not go to medical school, did not go to nursing school, is not capable of being a firefighter, I too can be a superhero through combinatorial optimization. Some of you didn't laugh. You're like, yeah. So we use combinatorial optimization to schedule residents, right? It is the most nasty Sudoku problem, and they solve it by hand typically. That's what we do, right? That's an integer programming model. And by the way, when we build schedules by hand, we're lucky to get a schedule that roughly looks like it works. And when we build it with combinatorial optimization, I can build in sleep patterns, your circadian rhythm, which in turn reduces depression, which in turn reduces suicide in our medical profession. I can improve continuity of care to make sure that things don't get missed in patients because one doc is handing off to another doc. Okay, you don't like combinatorial optimization. I don't really understand why, but if you're one of those, how about discrete event simulation? So now we can go back to this issue of access. So we have one open appointment. Should we give it to my dad who hasn't been seen before and is waiting to be diagnosed and treated? That seems really important, at least it is to me. But what about the patient who was seen 6 months ago and needs the next step of their treatment? Which one do we give the appointment to? And how do our policies impact things? There's randomness in the system. My experience, do we have any physicians in the room? If they're on Zoom, I have tremendous respect for my physician and nursing colleagues. They have skills that I do not have. We have skills that many of them don't have. And one is having some idea of how to think about uncertainty. How we think about uncertainty is, it's frequently very counterintuitive. And the notion that if on average I have 10 patients a week giving birth, I need 10 slots for delivery, that's not going to cut it, right? The notion of variability, predictive modeling, right? Again, when we have variability, if I can so we have a command control center, and one of the things that they do is they track our admissions and they track our length of stay. And when you go, gee, this is higher than what we were expecting to happen, they can start doing things like not doing elective surgeries, not doing planned surgeries, because now we're suddenly not going to have capacity for people. I can't give a talk without talking about generative AI because they won't pay for my travel expenses. So I'll talk about generative AI. I asked ChatGPT to add something to my slides, and they came up with patient visit summaries. No, in all seriousness, there is tremendous burnout, in part because of the burden of administrative work that perhaps does not need to be done by human beings. I am personally an advocate for bringing AI into the healthcare space for administrative purposes before we go all in on diagnostic and treatment planning. But even that, you know, we have to think very carefully about how we bring AI in. So, is there a way, sorry, my screen is covered by Zoom, so, you know, we'll just keep looking backwards. So, we have the potential to have tremendous impact, enormous impact. We are not there yet, which is not to say that there aren't lots of people doing amazing work out there, but it's not solving the problem, right? We are in crisis. So what is missing? What's going wrong? Number one, we solved the wrong problem. So I've sort of given it away, and some of you being in this room already know the answer, but we're going to pretend I'm going to count on you to give the right answer, which is wrong, okay? Okay. So you come in, you're a normal person who doesn't, that's implying that we're not normal. You're a person who doesn't understand variability very well. You don't know a lot about healthcare as a system, and you're reading the newspaper, and the newspaper says that the average time to get treated in an emergency department is 7 hours before you even get seen, and that the average waiting room, we have a report that I get daily that talks about the average, so weekly I get a report that says how many days this week was our average waiting room more than 35 people. And it's like 7 and 7 and 7 and 7. I don't know why we get this report anymore. So our EDs are overwhelmed. Therefore, the logical solution is to make what bigger? The ED, of course. We need more ED doctors or more ED nurses or just more emergency departments, right? Pushbender says no. He was my master's student. The reason that the emergency departments are so crowded predominantly is because my account needs attention. That's nice. The emergency department, okay, now I've lost my slides entirely, folks. The emergency department is crowded because some people coming to the emergency department are really sick and they need to be admitted to the hospital. You can't take somebody who's really sick and needs to be admitted to the hospital and send them home. But if there's no bed in your hospital, you keep them in the emergency department. There are times that we have more patients in the emergency department who are boarding, which means they're waiting to get a bed in the hospital, than are actually waiting to be treated in the emergency department. Hire more emergency room doctors, and you know what they're going to do? Maybe they could build schedules. Because it's not that they can't treat patients, it's there's no place to go, right? So if you try to solve emergency department crowding by improving the emergency department, you will not fix the real problem. Now I'm going to really age myself, but Katie Couric, anybody know who Katie Couric was? Okay, a couple of you. And for those of you who have no idea but nod anyway, again, this is good audience participation, and you get like one extra step towards heaven for it. So, all right. So, do you remember Katie Couric? Thank you. Do we think he does? Doesn't matter. Katie Couric was the Today Show or something, and in all, not funny, her husband died of colon cancer. And colon cancer is one of those diseases that when detected early has pretty good outcomes, and when detected late has really bad outcomes. That's why when you reach a certain age, they say you all need a colonoscopy, right? Because we want to catch it before you're symptomatic, because then you have a much better survival rate. So she had the bully pulpit, which is a great thing, and made a big push that people should, in fact, because nobody likes getting a colonoscopy. And so she made a big push. Some of you may know Mike Carter in Toronto. Mike is at the University of Toronto, does wonderful, wonderful healthcare policy research, and does a lot of work for the Canadian Ministry of Health. So Canadian Ministry of Health looked at this and said, we should start testing people earlier. We should test more people and test them earlier, which sounds wonderful, other than the fact that you have to get a colonoscopy, but if it's going to keep me from dying, I'm in, right? So he was asked to do some analysis of all of this. So here's the thing. If you tell a whole bunch of people to get a colonoscopy for no good reason, what's going to happen? Nothing. They're not going to do it, right? If you tell them that by having a colonoscopy, you are less likely to die, right? You'll get to see your children grow up. You'll get to walk them down the aisle at their wedding. You need a colonoscopy. Then people are going to go get a colonoscopy, right? Now, when you get a colonoscopy, there's a possibility of an incidental finding. An incidental finding basically means we found something that you probably would have died with 50 years from now when you had something else happen. Because we all have, if every one of us in the room got a full body scan, every one of us has something that now we got to worry about and we've got to follow up on. And by the way, I've told you that the reason you need to get a colonoscopy is so you don't, Wesley, say it with me, die, right? So now you've gotten the colonoscopy and I've seen something and I've said, oh, we need to do a follow-up. And then I tell you, okay, we need to do a follow-up and the next available appointment is in 7 months. And what does that do to your mental health, right? And by the way, while we are all getting colonoscopies, there's a small group of people with colon cancer who are now part of, you all know queuing and statistics and stochastic processes. If we've made the group bigger, some people who would have gotten it, if you say it used to be, I don't remember the ages, it used to be 40 and older, now it's 35 and older, there are going to be some 35-year-olds who get it before a 40-year-old who would have gotten it sooner, whose cancer would have been detected. And Mike Carter, basically, what he did is he did all of the analysis and he said, guess what? We don't have enough gastroenterologists. So now you're going to tell all of these people that they have to get this or they're going to, Wesley, die, but they can't get an appointment. And then a bunch of them are going to have something found and you're going to go to send them to an oncologist, but we don't have enough oncologists, right? Okay. I think I've made my point. So, number one, we can solve the wrong problem. Number two, in fairness, there are people whose lives were saved by that because they were 36 and had early stage colon cancer and it was caught and would not have been otherwise. So it's not that it was a bad idea. It solved a problem. It identified more colon cancer. The problem is, in the process, it also created a whole bunch of other things. Third thing, the world is messy. So I feel bad because some of you have been stuck with me at various times today and you're hearing things 2 and 3 times. But there are people who do theoretical research. This is really important and valuable. But it's only important and valuable because somebody else takes that theoretical research and applies it to a problem. And sometimes in applying it to a problem, they identify the need for more theoretical advances. And sometimes the theory pushes the application. Sometimes the application pulls the theory, and they go back and forth and back and forth. And I would argue, and I will argue and argue and argue, that there is a third rail, there's a third level of applied research typically, and again, very important, very essential, good people doing good work, but it is typically based on one of my favorite words, which is models. We model things. And then when we're done modeling it and developing the algorithm, doing the analysis, we publish. And in the same way that the theoretical work is important, only because somebody else takes the ball and then does the applied research, if you write a paper about applying stochastic optimization techniques to schedule surgeries, I'm going to say this carefully, and I'll still say it badly, but who cares? If somebody else, it doesn't have to be you. This is important. It's not that the theoretician is not doing important work if they don't do the application. And it's not that the applied researcher is doing bad work if they don't take it the next step. But if no one takes it the next step, it doesn't matter what we develop to improve healthcare if it's sitting in journal articles. And the reason that I've said this to some of you, I've had various people, including dean types, say, that's just consulting. So first of all, let's not disparage consulting, right? There are lots of people doing important, good work in consulting. But in addition, it is still research. If you define research as figuring out how to do something that no one has figured out how to do yet, and I got to tell you, waiting 7 months to see a neurologist means that all of the people publishing articles about stochastic approaches to new paradigms for access aren't done yet. So how do we do this, right? Somebody at some point has to realize that the terms of the nurse's contract impacts how your algorithm works. So what do we do about this? How are we doing? Let's think about medicine. I'm a big believer in steal what other people have done and take credit for it, or do something good and let someone else take credit for it if that's what gets it forward. So little side lesson, if you can figure out how to solve a problem in healthcare and you can let someone in the healthcare system take credit for that work, and that's what enables you to get it done, go for it. Go for it. So here's how people, in an ideal version, which is not always happening in practice, but ideally this is the way we train people in medicine. This is how it works. We diagnose underlying disease. We don't treat symptoms, right? We don't say, oh, since you have a headache, the appropriate response is I'm going to give you aspirin. The appropriate response might be I'm going to give you aspirin until I can figure out what's causing your headaches. But we need to know what's causing the headaches and don't just mask the symptoms. So if we're going to try and fix the fact that there are people spending hours and hours and hours in our emergency department, we need to figure out why, right? So we start in medicine by diagnosing the underlying disease, and we do that through qualitative and quantitative work, right? We get lab measurements, we do imaging, we look at you, we talk to you, we examine you, and then we don't treat the disease. Ideally, we treat the patient, right? So giving me a medication, giving me a chemotherapy that's going to kill the tumor that also kills me, it really doesn't matter if you cured the cancer, right? The idea of radiation treatment, any of you have seen these wonderful papers, right? The reason radiation is so challenging is the thing that is killing your tumor can also kill your spleen, right? How do we do this? Giving me a medication to take care of my liver that damages my heart is not the solution. So they treat this complex system, which is the human body. And then they monitor, they assess, and they adjust. So I've given you this medication, the side effects are intolerable. We maybe give you another medicine to treat the side effects, or we start with a different treatment. We find that you're not responding the way we had hoped you would. So we up the dose, or we try a different chemo agent, or we do something different. We move from radiation, chemotherapy, we move from medical to surgical treatments. And there was a time when you had a doctor. Little house on the prairie, there was Doc, and Doc just did everything. That doesn't exist anymore, right? We don't just have cardiologists, we have pediatric cardiologists, and we have pediatric interventional cardiologists, and we have something, right? So when you're trying to figure out the right way to take care of a patient, not the disease, but the patient, so you want to make sure about the side effects and the impacts and everything else, you bring in consultation. You consult with other providers. And by the way, we don't expect one person to do everything. So we have theoreticians who develop the fundamental understandings of genetics. We have bench scientists who work to develop new medications. We have people who run clinical trials, and we have people who do bedside care. And the person who is best at doing that gene therapy may not be good at bedside care, and that's okay, because we need all of them, and we need feedback loops between them. So ask yourself, which one of these are you? Because you don't have to be all of them. So here's my argument for how we cure our health system. is we have to diagnose the underlying problem. And that is not something that we have been trained to do. In medicine, when you go to medical school, you are trained to diagnose. We don't spend a lot of time in the engineering schools or the OR schools, the business schools that I've been involved with, teaching people how to figure out what the question is. We say, here's a problem, go solve it. Here's a problem, let me teach you a methodology. And I have had colleagues say, you know, it's so frustrating. I'm eager to help. And I sit down with this cardiologist or this nephrologist or this orthopedic surgeon, and they can't tell me what they want. That's because they don't know. That is where we have tremendous opportunity to make value, is to figure out. It is a complex system. They're like a specialist in one organ. They know the emergency department. They don't know how they intersect with all the other spaces. That's what we need to do, which includes observations and data analysis and engaging with stakeholders. And then we need to treat the system, right? Don't fix the emergency department if the way you're going to fix the emergency department just means that a whole bunch of surgical patients are going to be messed up, okay? So if fixing one problem causes harm elsewhere, you have not done your job. We have to monitor, we have to assess, we have to adjust. You take your solution and you go to implement it and you discover that, I didn't quite do as good a job as I should have, and I've discovered that my new OR scheduling algorithm, which is going to improve access and make sure that people can get surgery sooner, which is a great thing, has half of our nurses starting 30 minutes earlier in the morning, which unfortunately means that childcare doesn't work, and so they quit. We need to go back to the drawing board. And by the way, it's not, well, that's your problem, because you didn't fix it. And by the way, if we're trying to convince the health field that we have something to contribute and we just totally messed everything up, we need to fix it. So we need to be collaborating, and we need to be collaborating with medicine, but we also need to be collaborating with nursing. Nursing is very different than medicine. If you do not have family members or friends, or you have not spent time understanding the difference between the work that nurses do and the work that physicians do, this is a really important thing you should be doing. Totally different skill sets. One is not junior to the other. It is two different types of work. But we should be bringing in our biomedical engineering, our computer science. We should be bringing in public policy. We should be bringing in law and business. And I'm running out of time for all of my anecdotes. I'm sorry, but if anyone wants to come afterwards, I will tell you why we should have anthropologists to improve pressure ulcers on inpatients. And we should be providing, here is my pitch for the leadership here, we should be allowing people to see their slides without things coming up in front of them. We should be allowing people to say, I really want to do foundational theoretical research. And we should reward that and encourage that, but also find ways to make sure that that work ultimately becomes impactful. We should be allowing people to do this applied research. There was a period where applied research and theoretical research were not viewed as equally valuable, equally challenging, equally important. I don't know what to call it, but this third rail, the closest I could come up with is, okay, you're doing the theoretical or foundational research, and you're doing the applied research, and you're doing the research about how to make this work operationally. So I guess we could call it operations research, and then someone's already taken that title. So I was sort of out, but what do we call it? But how do you incorporate? Because it's not just that you need to know about the work rules for the nurses that take a break, but incorporating that rule in your model can make the modeling harder. And once you develop that new model, you may discover that now your algorithms don't converge quickly enough and you're cycling back. So I'm going to do a really quick example of some work we just finished. So ED crowds, really crowded, long waits. This is a problem. Actually, it's not a problem. What is it? It's a challenge, right? And the reason I say that is when you think about problems, I think about problem sets. And problem sets have an answer. And challenges have many answers, and we may need to incorporate many of them. So if I think about ED crowding, How do I fix ED crowding? Well, one thing I could do is reduce the input. If we got more people vaccinated, we would have less flu, and therefore fewer people would need to come to our emergency department, in which case our emergency department would be less crowded. So if I can reduce the input, if I can get them through the emergency department faster, or if I can get them out of the emergency department faster. Let's spend a little time on getting through, which doesn't mean that there aren't people here who should be working on the input or the output. We'll talk about throughput. What are the different ways you could do it? Well, maybe it is more doctors. Let's find out. Let's do some data analysis and figure out if we need more doctors. Or I could treat them faster, or I could diagnose them faster. Okay, let's talk about diagnosing. And I can't write on the boards in a way that's not going to make chalk noises, but think about, we've been spiraling out, right? So now we're going to talk about ways to diagnose them faster. Well, that could have to do with using AI to come up with predictions. It could mean being able to get consultations faster, maybe test results faster. And at some point we discovered that, you know what? The average length of stay in our emergency department is about 6 hours. The average length of stay, if you need to get a stress test, is 18 hours. That seems like an opportunity to explore. And I did have to have one figure at least. Okay, so this is just showing a group of patients. You'll see, ignore the blue. It's a little misleading. The reason the blue is there is to show that these patients arrive at any time of day, which is not what the ER docs tell us. The ER docs tell us that patients who need stress tests because they have chest pain all come in the middle of the night. No, they don't. They come in exactly the same time distribution as every other emergency department patient. But, so you show up, quick background, you show up at the emergency department and you say, I have chest pain. And they immediately launch a protocol. I love protocols, I'm an industrial engineer. And the protocol says, first, you do an EKG to make sure they're not actively having a heart attack. Second of all, you do a blood test for troponin. And if the troponin comes back negative, you wait 2 more hours and you do another troponin test. And if that comes back negative, you do something called a heart score to see how at risk they are. And depending on that score, you may order a stress test. So the blue is when they come, ignore it. The orange is how long it takes to get through those tests. It's protocolized. They do it pretty quick. It's almost the same for everybody. The red says, once I'm done with my stress test, how much longer do I stay in the hospital? It's the same for everybody. That big green thing, it's pretty variable. It's also really big. And that is the time that I'm lying in a hospital bed waiting to go get a stress test. And by the way, while I'm waiting for those 12 hours, my 83-year-old wife is in the waiting room trying to sleep in a chair and possibly catching COVID. And there are 4 other patients who are in the waiting room because I'm taking up a bed for 12 hours. So we wanted to look at this, and I'll just kind of jump to the punchline, which is, well, one way you can solve this problem is actually to discharge the patients and give them a stress test in the ambulatory setting. It turns out that the doctors are not saying you have to get a stress test because otherwise you'll, Wesley? Die. They're saying you need a stress test in the next couple of weeks, and it's a 6-week delay in the ambulatory space to get a stress test. Now we're ready to be industrial engineers. That's where we started with this. We were like, yes, so we're going to prioritize certain slots for you to get a stress test in the next 48 hours in the ambulatory setting. So now we've got a problem. How many slots do we reserve? At what point do we release those slots? Because we don't want the unintended consequence of delaying other people. Round and round we go. And in one of our conversations, we learned that when you're in the emergency department and they order a test, that's part of your bundle of care. But if you're ambulatory, if you're outpatient and you get this test, many insurance plans require prior authorization, and the delay for prior authorization is about 3 weeks. And we go, maybe that's not the right solution. Maybe it is. Somebody else later said to me, who cares? If the cost of eating, if the hospital cost of eating that stress test is substantially less than the opportunity cost of 18 hours of emergency department bed, give them a free stress test, right? These are the questions that we should be asking ourselves. We also learned that the highest cause of malpractice for emergency department physicians is missed chest, basically people having a heart attack after they leave the emergency department. So there's tremendous incentive to say, if we keep you And I'm being facetious. I have, again, enormous respect for our ED docs, but let's think about this. I can keep you here, not get sued, not have you die, which I would like. And by the way, frankly, it reduces the workload. And again, no one is thinking, ooh, if I keep this patient longer, I don't have to pick up new patients. But the reality is that patient in a bed is not really my problem. Or I could send you home, and there's a small possibility that you will, thank you, and I will get sued, and that's the incentives there are not great. So maybe the answer is not industrial engineering. Maybe the answer is to do some mathematics and some economics to prove that actually, from an insurance perspective, everybody is better off if we send these people home. Okay, so you're the only one who remembered. I'm heartbroken. These are my bumblebees. I'm very excited about this. We discussed this at lunch. Evidently, nobody was paying attention. But so somebody asked, well, how do you do this? Because to me, this is just what we do, right? I mean, this is just how we think about the world. And so I don't feel like there's anything special in what I do. And then I realized, but my husband doesn't think the way I do. And lots of people in the healthcare system don't think the way I do. So this idea of let's start with this challenge, reducing ED crowding. Now let's take that challenge and say strategy one, reduce the number of people coming to the emergency department. Or we could reduce, oh, that's a daisy, by the way. It's not a beautiful daisy, but I'm kind of proud of it. Diagnostic analysis of integrated systems via industrial engineering. Come on, thank you. Right. But the idea is we were trying to figure out how do we keep track? Because in our conversation about fixing this, people are like, well, stress testing's like 5 patients a week. You're not going to solve all of the problems. And we're like, yeah, but for those 5 patients and their 5 83-year-old wives and the 5 times 4 patients in the emergency room waiting room, it's better than not doing anything. So I want to keep track of all of my other stuff. So we start drawing these pictures. So once we get to strategy 5 and we say, we're going to reduce throughput, that becomes the center of my new flower. And then I start saying, well, we're going to do it this way. That's not the way other people think, which is shocking to me. But that idea of keep peeling it back and peeling it back. And at some point, what we discovered was, well, we reserve slots for ED patients to get stress tests. And we reserve them. The clinic runs from 8 in the morning till 4 in the afternoon. And the 9 o'clock, the 10 o'clock, and the 12 o'clock slot are reserved for the emergency department. Why? Because the people who built this don't know anything about stochasticity. Because they weren't trained in industrial engineering. They went to medical school, right? And we said, you know what? If you reserve a 3 o'clock slot and a 9 o'clock slot, you're going to see a 6-hour reduction on average in the time people wait for a stress test. And do you know what the cost of making that change is? Well, what are you going to do to inpatients? Because if you've got an inpatient waiting to get a stress test in order to get discharged and you mess them up, now they stay an extra. No. The clinic basically said, we talked about what is the impact on ambulatory, what is the impact, and they said, we'll go into Epic and we'll flip a switch that says the 3 o'clock is now reserved for the ED. The 12 o'clock is now not reserved, and we're done. Did that solve everything? No. But it took us like 3 weeks, and there are still some patients who are going home. And we also learned about the prior authorization issue, and we also learned about how inpatient uses it. And we also identified that, we're reserving 3 slots a day, but the probability of needing all 3 is really low. And that means that your ambulatory patients are waiting longer. And now we have a new flower with a new petal to say, let's do this other thing. So what I want to jump to is one more thing. Yeah, I'll jump. Well, okay, I drew a picture, so I want to show my picture. You wouldn't believe how long it took me to make the damn triangle. It's like, this is where I should have been using ChatGPT, right? But I want you to think about theoreticians typically work alone. they work within their discipline. In many cases, they're very happy doing that, and that's fabulous. So we've got this one end of the spectrum, which is, I do work in my discipline, and it is deep. Fabulous, you're on the left. We have applied people that I tend to think of, for the most part, when I say application, it's I as an industrial engineer working with you as a cardiologist. And and there are two disciplines, and there's an increased engagement. Where I'm currently working is in the space of this far more applied operational, where we need to be talking to people in public health. We need to be talking with people in anthropology. We need to be talking. So it becomes more diffuse. That doesn't make it less valuable. But if you're the person who should be working over here, then you should be working over here. And if you're the person who should be working over there, we need to start calling it research, please. Is it engineering research? Is it public health research? Do I care when I'm on hour 422, literally waiting to get out of the ED into an inpatient psychiatric bed? It is still research, and it's something that we should be valuing and encouraging. And so what I want to emphasize as we wrap up for students, for the faculty, is these ideas that this stuff matters, first of all. It is really rewarding as an engineer to have a physician say to you, literally, you were involved in that work. I can't tell you how many lives we saved because of that, right? Didn't die, Wesley. They didn't die because of us. You can be anywhere along this spectrum, and part of the role of people like me is to facilitate, hey, if we had an algorithm that could do X, Y, Z, we could solve this problem. Let me go to my theoretical friends and say, here's a really good topic for you to work on. Or to go to my theoretical friends and say, what are you working on? Hey, that might actually help us predict preterm delivery of babies, right? We are central to this how do I find, diagnose, understand the problem and its systems connection. We are at the core of that, and then we pull in, this needs public health work, this needs work from the law community, this needs work from the humanities, okay? There's room at the table for everyone, and I think that's it. I'm okay, right? 4 minutes to, all right, thank you very much. Oh, wait, now we're done. Now we're done.